Three, two, one. We are on live. We are good to go now.
Okay, thank you. Good afternoon, everyone. It's a great pleasure to have you all here. I'm Dr. Omkar Ok, working as a medical advisor at Hetero Healthcare. Our topic of discussion for today is experience sharing program on managing postpartum hemorrhage. The purpose of today's meeting is to have a better understanding of the management of postpartum hemorrhage and the role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is serving in the healthcare industry since more than 25 years. It has more than 300 products in its portfolio and has an employee size of 21,000. It is among the largest manufacturers of ARV, API, and FDF in the world. It has 36 state-of-the-art manufacturing facilities and has its presence in more than 126 countries. It also has Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs, reaching to customers across India. And it also has wide product range encompassing multiple specialties. Hetero has a distinction of bringing 4 biosimilar products to market within 5 years of initiation. Now, I would also like to introduce our speaker for today's meeting, that is Dr. N. Ramyakrishna ma'am.
Good afternoon, everyone.
Currently, just a second, ma'am. I will just, if you allow, I will just introduce you and then I can hand over the session to you.
Okay.
Ma'am is currently practicing at Sri Krishna Nursing Home in Chilakalipeta. She is reproductive medicine and IVF consultant, and she has done fellowship in infertility and ultrasound. She has overall experience of 15 years. So with this, I welcome you, ma'am, and hand over the session to you.
Okay. Good afternoon, everyone. I am Dr. Ramyakrishna. Today, I wanted to discuss with you all regarding the most important topic of interest to the gynecologist, that is postpartum hemorrhage. Let us go into the brief details of what is postpartum hemorrhage. Postpartum hemorrhage is nothing but loss of at least 500 ml of blood following vaginal delivery and 1000 ml following cesarean section. PPH is common and can occur even in women who are not at risk. PPH is the leading cause of maternal mortality in low income countries, and this is the primary cause of nearly 1/4 of all maternal deaths globally. Next slide, please. When coming to the incidence, the postpartum hemorrhage is an unfortunate but common. The maternal mortality, the leading cause of maternal mortality, accounting for about 35% of all maternal deaths. Maternal mortality ratio in developing countries was around 240 per 1 lakh live births, compared to only 16 in developed countries. Global postpartum hemorrhage incidence. 14 million women suffer from PPH every year. The incidence of postpartum hemorrhage is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. Postpartum hemorrhage incidence in India. 38% of the maternal deaths are due to postpartum hemorrhage in India. 25% of 25.7% of global deaths takes place in India, and 2/3 of these attribute to PPH only. India has an unexpectedly high maternal death rate of 540 per 1 lakh live birth. Next, please. What is the etiology of postpartum hemorrhage? It may be the tone disturbances, that is uterine atony, that is inability of the uterus to contract, which may lead to continuous bleeding from the uterine musculature. And the problem may be in coagulopathies, that is failure in clotting after the delivery. And maybe trauma may be the cause, like uterine trauma, that is injury to the birth canal, rupture and uterine inversion and lacerations to the birth canal. Maybe retained products, that is tissue, retention of placenta or placental bits or abnormal placentation and remain retained clots may be the reason behind postpartum hemorrhage. We have to rule out all these causes, that is stone, thrombin, trauma, and tissue. Next. What are the clinical findings we usually see in postpartum hemorrhage? Abdominal tenderness and circulatory disturbances, increasing abdominal girth, loss of uterine contractions, maternal tachycardia, and vaginal bleeding. Coming to the clinical findings in PPH in degree wise, initially compensatory phase, later increased to mild, moderate, severe shock. During compensatory phase, the blood loss may be around 500 to 1000 ml. That contributes to 10 to 15% of the total volume of the blood. The blood pressure change, that is systolic blood pressure, there will be no much change with this much amount of the blood loss. What are the symptoms and signs during this compensatory phase? Mild palpitation, mild dizziness, and tachycardia can be seen in some cases. When it is called mild degree of shock, the blood loss reaches 1000 to 1500 ml, that is 15 to 25% of the volume of the blood is lost, and the blood pressure, systolic blood pressure, becomes 80 to 100, and the symptoms include weakness, sweating, tachycardia. And when the shock becomes moderate, the volume of the blood is 1500 to 2000 ml of the blood is lost, that is 25 to 35% of the total volume of the blood. Then there will be marked fall in the systolic blood pressure. This will lead to restlessness, pallor, oliguria. In case of severe shock, where 2000 to 3000 ml of the blood is lost, which is corresponding to 35 to 45% of the overall volume of the blood. Then the systolic blood pressure falls to 50 to 70 mm of mercury. The signs and symptoms include collapse, air hunger, and anuria. Next, please. How to approach a case of postpartum hemorrhage? Poor uterine tone. How to check this? The clinical findings when there is poor uterine tone is on abdominal palpation, uterus feels relaxed, boggy, and soft. Uterine fundus may be felt above the umbilicus if uterine cavity is filled with blood and clots. During such conditions, the investigation should be full blood count, coagulation profile, and urea and electrolytes should be done. If patient is not responsive to fluid and blood replacement, then abdominal ultrasound should be done to exclude uterine rupture or intraperitoneal bleeding. How to manage such case? Uterotonic agents like oxytocin, prostaglandins, and ergot alkaloids should be given. Uterine balloon tamponade is the last option. Hemostasis algorithm, surgical management should be done. When we find tears or trauma in the genital tract, then the clinical findings will be bleeding from areas of trauma within the genital tract, like uterine rupture, extension of uterine angles, tears during cesarean section are the examples. Extragenital causes include subcapsular liver rupture, rupture of ovarian vessels, rupture of splenic vessels also may cause the blood loss. During such conditions, the investigations include inspection during cesarean section by exteriorization of the uterus, and ultrasound may help identify free fluid in patients with uterine rupture. How to manage such conditions? Who have to repair identified genital tract trauma, and the treatment is pelvic arterial embolization. It may be required in cases of broad ligament or supralevator hematomas. When the PPH is suspected to be due to retained tissue, the clinical findings, retained placenta and membranes, they are identified during bimanual examination. Investigation in such conditions shows examination under anesthesia. What we should do in such condition: manual removal of placenta, retained products of conception under regional or general anesthesia is preferred. When we suspect coagulopathy is the cause, clinical findings will be continuous bleeding when the uterus is contracted well. Then the investigation should be urea and urea electrolytes, full blood count, and coagulation profile should be sent. Management is medical management, that is, immediate replacement of blood and coagulation factors and platelets. And surgical management include only with the trauma or atonic hemorrhage unresponsive to medical management, then go for surgical treatment in such cases. Attempts should be made to identify the cause in women who are bleeding in parallel with resuscitation. This should be the ideal management protocol. Next, please. Rationale for the development of carbetocin in new heat stable formulation. Carbetocin is available in a room temperature formulation and convenient while presentation. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between 2 to 8 degrees centigrade. Resource poor countries do not always have cold chain transport and storage capabilities. So there is a need for refrigeration in such conditions. E present carbetocin is stable at room temperature, has shelf life of 24 months at 30 degrees centigrade and 75% humidity. Avoids need for cold chain storage and logistics. Is provided in a convenient vial form. Next, use of uterotonic agent. Time of administration. Uterotonic agents are usually administered at the crowning of baby's head, at the delivery of anterior shoulder, or at the end of second stage of labor, or following the delivery of placenta. For prophylactic use, that is prevention of PPH and active management of third stage of labor also we use. During therapeutic use while managing PPH. The molecules commonly used are oxytocin, carbetocin, ergometrin, symptometrin, and misoprostol. Next, carbetocin is a next generation drug for PPH management. Carbetocin was created by making several modifications to the oxytocin structure so that its half-life is prolonged and the enzymatic degradation is reduced. This is a synthetic long-acting analog of oxytocin. Therapeutic indication: prevention of PPH due to uterine atony. Posology and administration. One vial contains 100 micrograms of carbetocin in 1 ml solution for injection. Next. Characteristics. Characteristics of oxytocin and heat stable carbetocin are compared. The brief description. Synthetic oxytocin is synthetic cyclic peptide form of the naturally occurring posterior pituitary hormone. It binds to oxytocin receptors in the uterine myometrium, stimulating the contraction of the uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. The heat stable carbetocin is long acting, it is synthetic, and it is the analog of oxytocin with agonist properties. It binds to oxytocin receptors in the uterine smooth muscle, resulting in rhythmic contractions, increased frequency of existing contractions, and increased uterine tone. Pharmacokinetics. Intravenous. When oxytocin is given IV, almost immediate action with peak concentration after 30 minutes is achieved. When given intramuscularly, slower onset of action, taking 3 to 7 minutes, but produces a longer lasting clinical effect of up to 60 minutes. Half-life of oxytocin is 1 to 6 minutes. When come to the pharmacokinetics of heat stable carbetocin, when given IV, sustained uterine contractions within 2 minutes, lasting for about 6 minutes, followed by rhythmic contractions for 60 minutes. When given IM, sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for 120 minutes. The half-life of carbetocin is 40 minutes. Storage and transport. Oxytocin requires protection from light and storage at 2 to 8 degrees continuously to preserve its activity. Carbetocin should be stored up to 30 degrees. Clinical indications. Oxytocin can be used for induction of labor, augmentation of labor, prevention of BPH, and treatment of BPH. But heat stable carbetocin is best for prevention of BPH only, not used for other indications. Next, please. What the clinical evidence shows. Carbetocin was found to be non-inferior to oxytocin according to the largest trial conducted by WHO, that is Champion trial. The study, next please. Cochrane. So the study revealed that, concluded that the frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus oxytocin. The use of additional uterotonics agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. Carbetocin was found to be non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. Next. Cochrane review. Carbetocin for preventing postpartum hemorrhage. From the 11 studies involving 2,635 women were included, it is concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. And also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. Next, what are the guidelines recommend? WHO guidelines 2018 recommend only one of the following to be used as a prophylaxis for PPH. either oxytocin or carbetocin, misoprostol, ergometrin or methylergometrin, oxytocin and ergometrin in fixed dose combination. According to Canada Guidelines 2009, carbetocin is the best for prophylaxis of BPH. New Zealand Guidelines 2017, active management of third stage of labor and prophylactic uterotonics of anything. FIGO guidelines, carbetocin, one of the recommendations for PPH management. Germany, Austria, Swiss body recommended carbetocin, slow IV. France recommends carbetocin on proving non-inferior to oxytocin, achieved by champion trial. Next, please. So my experience, I wanted to share my personal experience while using this carbetocin. Previously, I used to think that during normal delivery, the blood loss is a little bit less. So I should use oxytocin like that. But when compared to when I started using carbetocin, then I found that compared to when we use oxytocin, the amount of blood loss was found to be significantly reduced during normal deliveries also in carbetocin, because when we prophylactically use oxytocin, I observed around 250 ml of blood loss over 15 minutes like that. With the carbetocin, around while observing normal delivery for first 15 days, I used to observe only 50 to less than 100 ml of the blood loss only I observed. So I found very much useful in doing in using prophylaxis, particularly in vaginal deliveries. That too in complicated vaginal deliveries like big babies, polyhydramnios. So recently I did deliveries where she is G3 para 2 living 2 previous to normal deliveries. The weight of the baby is 2.8 average, but she is with over distended abdomen due to polyhydramnios. So I suspected PPH because of the over distension, and she is a bit anemic also. When I used prophylactically the carbetocin immediately after the delivery of the anterior shoulder, I found very less amount of the blood loss, that is around 150, less than 150 ml. And later, after 1 hour, I thought I have to continue for as she is anemic. I don't want to lose minimal amount of blood also, blood loss also. Then I continued oxytocin, 3 ampoules in 5% dextrose for another 8 hours in a slow drip. This is my experience during normal delivery, one of my case. And next comes the during cesarean section. Initial days, I used to prefer for only high risk cases, like past dates with big baby, where I suspect uh, tonicity abnormalities. I used to give carbetocin. But nowadays, I used to give for every single case, because few cases, thyroid cases, obese cases, severe anemia cases, maybe with history of fever in recent 10 days before delivery, they are also tend to more blood losses. Though, so actually, initially, I used to uh, use as a prophylaxis in C-section cases like past dates with very big baby with cephalopelvic disproportion. So I used to give carbetocin immediately after the delivery of the head during cesarean section. The contraction of the uterus was very nicely observed within half minute, and the blood loss was less than 300 ml even in cesarean section with such big baby and past date case also. Nowadays, I am using for regular cases also. So that is my experience during initial days with the C-section. Nowadays, I am using for every case. in high risk pregnancies. Initially, I used to use Carbetocin from last 5 years. But initial days, I used to prefer for high risk pregnancies like primary with complications like pregnancy induced late onset pregnancy induced hypertensions and GDM where big baby and shoulder dystocia are suspected, where polyhydramnios is suspected, and where twin gestational days that is also one of the high risk causing over distension of the uterus leading to tonicity abnormalities because of the calcium there will be difficulties in contraction because of the calcium calmodulin differences in such cases. So initial days I clearly observed in PAH cases and GDM cases and twin gestational cases there is very less used. Previously we used to fear a lot and we used to take consents in large number of papers from every patient, husband and parents, in-laws by fearing the PPH chances. But these days, we are not at all fearing. For any of such cases, we are taking very confidently to the section, these high risk cases. We are very comfortable with the Carbetocin, a great molecule. Thanks for the innovators and thanks once again, hetero people. You are also providing such good molecule to the obstetricians. This is my experience.
Thank you so much, ma'am, for sharing your valuable insights. Now we move forward to the next part of our session, that is panel discussion, where we'll be having
Oh,
frequently asked questions and real world scenarios. So,
oh.
moving to the first question. So, ma'am, considering the use of carbetocin as a first line drug, basically to prevent postpartum hemorrhage, what are the benefits or advantages does it offer as a first line drug?
Because what I see is we have to use repeated doses of oxytocins so that the medical complications will be more with oxytocin. Liver profile we have to check. We have to think about water retention. There will be little bit of decreased urine output post-operatively when we use more number of oxytocins. That we have to be cautious. With Carbetocin, we don't need such monitoring. So there will be no fluid retention, though no decreased urine output, but it has long half-life, long duration of action, immediate and long action, and no complications immediately after giving like nausea, uh, like that, no respiratory compromise. It's a very best molecule. Preferably, I am using for its a prolonged half-life, prolonged action, immediate action, and retention of water, decreased urine output. For these causes, things, I am using preferring Carbetocin over the other uterotonics.
Okay. Means we can say that, ma'am, considering both the efficacy and safety, carbidocin would be a better choice and can be used as
Yeah,
a first line. Okay.
yeah.
Moving to the next question, ma'am, what are the patient profiles where doctors can anticipate in patients postpartum hemorrhage?
Postpartum hemorrhage in twin pregnancies where polyhydramnios over distended uterus is present, in severe anemia cases, in thyroid cases, in preeclampsia cases, GDM cases, and where patient pregnancy induced hyperbilirubinemia cases, will have some medical disorders also there, where we can expect PPH and elderly primaries, IVF pregnancies, etc.
Okay. Thank you, ma'am. Moving to the next question. So, ma'am, oxytocin, as it is used for labor induction, so in such cases or in such patient, can after the oxytocin, can we use carbitocin for prevention of postpartum hemorrhage?
Definitely, we can use because oxytocin, it is analog of oxytocin only, na? So initially, where we use oxytocin for labor induction, its half life is less than 30 minutes. Immediately, it will take action within a fraction of seconds, but half life is 6 minutes. But sustained action not will not continue more than 30 minutes. So, as it is a analog of oxytocin only, it uses only oxytocin receptors only. So, we can safely use carbetocin for the prevention of BPH in those cases where oxytocin is used for induction of labor. Definitely.
Okay, okay. Thank you, ma'am. Moving to the next question, as ma'am, IV route is the preferred choice and preferred route in majority of the cases. So if we means modify the question a bit, are there any scenarios or cases in which IM route can be preferred over IV route?
As where we suspect maximum PPH chances are there, where I used to prefer IV route for its immediate action and sustained action. And where I used to continue follow it with followed by other uretrotonics later. Uh, for simple cases where we do not suspect some routine PPH, simple cases, we don't want to use any other uterotonics next. We can use IM route because it has a prolonged action. The action is lasted for more hours. It acts immediately, but more hours of half-life it will be there for IM route. For simple cases, we can use IM route. For suspected PPH cases, I wanted to use IV followed by
Okay, okay,
when its action is going to be decreased, then I used to add other
okay.
uterotonics. Mm.
When we want delayed or a bit long-term action and the other
Long-term
uterotonics, we are not going. Okay, okay, yes, yes. Moving to the next question, ma'am, you have already explained about the safety of carbetocin. If any additional comments or points, if you would like to add on tolerability and safety of carbetocin.
It is very well tolerated, carbetocin, no immediate headache or no nausea. Some anesthetist will tell that a little bit hypotension we observe while using carbetocin. Anesthetist they will tell like that, but is not that much significant.
Okay, okay,
Patient side, no complaints. Anesthetist will tell that little bit of hypotension we observed after carbetocin. Like that, they will, when we ask them what is the difference you observe with oxytocin and carbetocin, sir, then only they will tell little bit of immediate hypotension, any low, just 5 to 10 points of systolic blood pressure drop. We can expect with carbetocin. Other than that, nothing is no
okay,
other
okay.
complicated
Does not go in serious category.
no category, no serious category.
Okay, thank you, ma'am.
Yeah.
Moving to the next question. So, if the patient is not responding adequately with carbetocin, then in order of preference, which additional uterotonics would you use?
Uh, Usually, first, immediately after carbetocin, I wanted to add oxytocin, 3 to 4 ampoules in 5% dextrose. When even after that, if is after 1 hour of surgery, if we check the pads, if we found any clots like that, then I will prefer to use prostadine. Maybe the third choice we can tell, because immediately carbetocin then followed by oxytocin if we suspect in high risk cases. When these two drugs are unable to control the bleeding, then my next choice is prostadine. It works better when combination with the carbetocin.
Okay, okay, okay. Thank you, ma'am. Considering the advantages of carbetocin, as you have already commented and explained, any additional comments on this, ma'am? Advantages of carbetocin over other uterodonics?
It is heat stable. It can be kept in theater, not in different medical shop in medicine. So heat stable, half life is more, and shelf life is also more. No complications, patients wise. Clinical symptoms or complications will not be there. So easy to store,
Okay,
long
okay.
half-life and shelf life. That is the best thing.
So, ma'am, can carbetocin be used or should it be used as a first line or should it be kept as a reserve drug?
It should be used as a first line.
Okay, okay, yes. Hence, it has an indication to be used as a first line, and there is no need to keep it as a reserve drug, considering its both
Reserve. Yeah.
safety and efficacy. Okay, okay. So moving to the last question, ma'am, if you have to summarize your entire experience of carbetocin, be it its safety or efficacy, its experience, and how does the
Yeah.
patient respond? So,
Okay. I can describe my practice as before carbetocin, after carbetocin. Before carbetocin, we used to fear a lot regarding the high risk pregnancies. We have to take consent for blood transfusion. We have to contact blood banks for reserve is there or not regarding the which blood group we want. We have for every case we wanted to have all these details. Blood ready is there or not. With the carbetocin, after the carbetocin we started using carbetocin since last 5 years, we didn't transfuse the blood for the PPH case.
okay,
That I
okay.
can tell. That is my. So
Means,
our health is also. We don't get panic. Any type of third cesarean section also between pregnancies or whatever may be the case. Recently, we did placenta accreta case where the placenta encroached into the bladder also. Then also a large number of doctors referred the case to GGH. But we did the case with only 2 units of blood transfusion because immediately after the baby delivery with such abnormally over hypertrophied placenta also the uterus was contracted very with the combination of carbetocin followed by prostaglandin also we have given. And after baby delivery, we did a cesarean hysterectomy. That's a nice experience. Because of the carbetocin, I confidently took the case so that I can. I'm confident that there will be no much loss during the procedure of cesarean or hysterectomy. So very good
okay,
drug.
okay. We can say that it adds to the patient's safety.
Definitely. Mm.
Yeah, okay. So this brings us to end of our meeting. And so thank you so much, ma'am, for sharing your valuable insights, sharing all the cases and where carbetocin can be used, its efficacy and safety. So there are no additional questions from the audience which are not already answered in the panel. So I would also like to thank all the delegates for their participation. And yes, thank you once again, ma'am. This marks the end of our meeting and we can close the meeting now.
Thank you everyone who attended the program and thank you Hetero Group for giving me the opportunity to revise my knowledge and share my experience. Thank you, one and all.
Thank you. Thank you so much, ma'am. Yes.